Well, I want to welcome everybody to our next lecture for the virtual Fellow Track Symposium. Today, we have Dr. Meyer Kattan from Columbia University, and Meyer is going to be speaking on respiratory disorders in children infected with HIV and with other immunodeficiencies. Meyer has been one of the leaders in this area and was on the front lines during when HIV really came to be widespread, and New York City was greatly impacted. So he can tell you what it's like. Before Meyer starts, I just want to remind you that the next symposium will be Pulmonary Hypertension by Jeff Feynman, and that's Monday, July 13th at 4 p.m. And then also after that, Sharon Dell will be talking to us on Wednesday, July 15th at 4 p.m. about lung manifestations of rheumatologic diseases. It's really important for everybody to do the evaluations of the talks and of the symposium overall. So please feel free to make recommendations for future activities, and remember to complete the evaluation for today's lecture. Also, we're still trying to schedule 2 more talks, one on primary ciliary dyskinesia and the other on cystic fibrosis, so you'll be seeing notice about those as well. And with that, I'm going to stop sharing my screen and turn it over to Meyer, and he'll take it from here.
Okay, hello everybody. I'm going to talk about respiratory disorders in children infected with HIV and with other immunodeficiencies. Can you make the slide go down? Next slide. Yeah, I have no disclosures. Next slide. So it's important that we understand the public health lessons that the HIV epidemic provided. And, you know, I had the slide last year. It even makes more sense this year when we have a COVID epidemic. And again, there are public health lessons to be learned. And I think 40 years later, we haven't learned all of them. And we'll try to apply the lessons from HIV infection to other immunodeficiency diseases. And then I'll talk about developing an approach to diagnosing pulmonary complications associated with immunodeficiency diseases. Next slide. So there are primary immune deficiencies and there are secondary immune deficiencies. The primary immune deficiencies are intrinsic defects in one or more compartments of the immune system. The secondary immune deficiencies are actually probably a little more common in what you all see for consultations on the pulmonary service. You have the kids who are on immunosuppressive therapies, viral infections like measles and causes immunosuppression, organ and hematopoietic transplants, malnutrition, and severe burns. Next slide. So you can have the certain cells that are involved in these immunodeficiency diseases. You have the B cells, and that usually results, if you have a deficiency in B cells, you usually have recurrent respiratory tract infections with encapsulated bacteria. If you have T cell deficiencies, like in you can get severe viral infections, fungal infections, and pneumocystis. And if they're disorders of the phagocytes, you'll get pneumonias and infections with catalase-positive organisms like chronic granulomatous disease. If you have a complement deficiency, you get you can get infections with encapsulated bacteria. And if you have natural killer cell deficiencies, you can get herpes virus and malignancies. You're more susceptible to that. Next slide, please. So with B cell deficiencies, common organisms are pneumococcus and H. flu. You can get staph and some enteroviruses. With phagocytic deficiencies, again, you have gram-negatives, E. coli, Klebsiella, Pseudomonas, Cepacia, Salmonella, and gram-positives, you can get nocardia infections, you can fungal infections like Aspergillosis and Candida. And with T cell deficiencies, you're more likely to get mycobacterial infections and the viral infections like CMV and EBV and herpes virus and other viruses, pneumocystis, and some of the rarer organisms like toxoplasmosis. Next slide. Next slide, please. Yeah. So it's, you know, now we have more and more measles. And I think that in our days, we used to see measles and its complications much more frequently. But now it's starting to come up. And really what we were worried about in those days was, at least in the United States, was SSPE, the encephalitis that's associated with measles. But in fact, that's rare, but it's a devastating outcome. In the economically deprived areas, like in Africa, the problem wasn't SSPE. The problem was that measles was such an immunosuppressive disorder that once they got measles, they got bacterial pneumonia and would die of pneumonia, not of measles. And so that's something to keep in mind, is that measles and HIV are both cause immunosuppression and predispose you to getting severe pulmonary infections. And so that, and in fact, the respiratory complications for measles are the biggest cause of mortality. And now, as I said, now that we're seeing measles again, you have to keep that in mind. The other thing is just, you know, you're taught not to do PPD or tuberculin testing after measles vaccine. And the reason is because you may get a false negative test. And the other thing is that after measles, a lot of children in areas where their TB is very prevalent would end up with tuberculosis or get scrofula. So again, it's the immunosuppression of these diseases that results in severe pulmonary infections and possibly tuberculosis. Next slide, please. So it's important to understand the approach and management of respiratory problems in immunocompromised children. And HIV gave us really a lot of information about immunodeficiency in general and helped us understand what we see now in with organ transplantation, with bone marrow transplantation, and other immunodeficiency states. Next, and the other point that it's important to know about HIV because it's still a very prevalent disease. It affects a lot of people all over the world, and there's adolescents in the United States that still have HIV. Next slide. So I'll go over the epidemiology of HIV and some pulmonary manifestations in the era before highly active antiviral therapy, and that were HART is the acronym, and talk about the long-term pulmonary consequences of HIV infection. Next slide, please. So right now we have children who are get HIV through vertical transmission. They're adolescents with HIV, and there's obviously a huge population of children who are HIV exposed in utero, but end up with no infection. And that's the largest population that we have now in the United States. And the question is, what is the long-term outcome? And those studies are still really, we don't know all the answers. Next slide. So it's caused, HIV is a retrovirus. It's synthesized from RNA through reverse transcriptase, and then it gets integrated into the host DNA genome. And it affects cellular immunity. The CD4 T lymphocyte in particular is the main target. And you get a depletion of the CD4 cells. And you also end up with some B cell dysfunction as well, which affects humoral immunity. Next slide, please. Transmission can occur in utero, intrapartum, through breastfeeding, through sexual abuse, sexual transmission, drug abuse. And in the old days, it used through blood products. But now the blood supply is tested, and we don't really see that mode of transmission anymore. Next slide. So just, this is the way it started. In June 1981, in MMWR, they reported 5 young men, all active homosexuals, were treated for biopsy-confirmed pneumocystis at 3 different hospitals in Los Angeles. 2 of the patients died. All 5 had laboratory-confirmed previous or current CMV infection and Candida mucosal infection. Case reports follow. And so that's 1981. Next slide. Next slide, please. Yeah. And it was only 2 years later that they actually found the virus. And so it took a while. Unlike COVID, where we know what's going on pretty quickly, sort of what's happening with COVID in a few months transpired over almost a decade when it came to HIV. Next slide. Now, in 1983, only 189 women were reported with HIV, and 21 infants with opportunistic infections and unexplained cellular immunodeficiencies were reported to the CDC. So so it wasn't very common at the beginning. The next slide. And the people that were affected end up being stigmatized. It was called the 4-H Club: homosexuals, Haitians, heroin addicts, and hemophiliacs. Hemophiliacs were getting it from blood transfusion or blood products. And so these people were really ostracized, and it was, you know, a difficult time. In fact, the stigma, if you look at homosexual, you see GRID next there. What GRID is gay-related immune deficiency, and that's what it was called. And so it stigmatized a whole population of people. Next slide. A breakthrough came in 1994 when the first drug was given to try to prevent infection in children, in the newborns, and that was with AZT or Zidovudine. The problem here was that there were some, you know, ACT UP, which was a group of an activist group for the homosexual community, and to try to put AIDS on the map. And really, they did a good job. In fact, you may have heard just last month, the founder died, Larry Kramer, and they had a lot of positive things to say, although at the time he was really a thorn in the government side and everybody else's side. But interestingly, so he was representing one group of people. And in those days, pregnant women it was not recommended that they get antiretroviral therapy. So this study that I haven't shown you on the slide here was a controlled clinical trial giving pregnant women Zidovudine and a control group that did not get it. And ACT UP actually got very upset at this protocol and started to demonstrate and actually threatened the lives of the principal investigators for doing this study. And however, it was a landmark study, and the next slide will show you the results. It had, next slide, please. This is looking at the probability of transmission on the vertical axis the probability and you know, over the weeks of how many got HIV. And you can see there was a huge reduction with the Zidovudine group. The probability of transmission decreased from 25% to 8% in this study. And now that we have many more antiretroviral drugs, the transmission rate is less than 2%. So that was a major breakthrough for children. Next slide. Right now, though, there's still a lot of children living with HIV because not all pregnant women end up getting antiretroviral therapy. And there's 180,000 children in 2017 became newly infected, and 110,000 children died of AIDS-related diseases. So it's still a worldwide problem, and the problem still is access, although that's getting better. Next slide. In the era before HAART, so just to show you what immunodeficiency does, absence of CD4 cells, pulmonary manifestations were the most common. Over half the children, that was we're talking about the initial presentation. And lymphadenopathy, hepatosplenomegaly, failure to thrive, recurrent sepsis, and thrombocytopenia. And these children would come in, being well, and then very quickly developing some of these symptoms. Next slide, please. So in between, as I showed you, in 1983, there were only 21 cases. This is just at one site. This was at Mount Sinai, New York. We had 52 children with AIDS admitted to the hospital. They presented very early on. Usually the median age of the initial respiratory symptoms were at 6 months. And a third of them had respiratory failure and ended up on respirators. And the mortality was very high, although the mortality that we had was better than most places because we were seeing the most patients. But and they were dying of pneumocystis and bacterial pneumonia. And that was the cause, those were the most common causes of respiratory failure. So treating the mothers with Zidovudine really helped a lot in reducing, in controlling this epidemic in children. Next slide, please. And the complications that we were seeing were mostly pneumonias. We were following a cohort. This was a multi-center study of HIV-infected women, and followed their kids after they were born. And some of the kids obviously were not infected, and some of the children were infected. And this is comparing the groups that were infected and not infected. And you can see that the ones that were infected had much higher rates of pneumonia, at that time we weren't doing viral PCRs, so I'm sure the viral pneumonias would have been much higher. Bacterial pneumonias were higher, pneumocystis was higher, obviously, but upper respiratory tract infections were the same. Next slide. And the pulmonary infections were, if we look at the right-hand panel with PCP, the pneumocystis, this is looking at the CD4 cell counts. And the blue line is children who were not HIV infected and who didn't have pneumocystis. Their CD4 counts were really pretty stable and high. And if you look at the gray line, which are HIV infected and ended up with pneumocystis, they had precipitous drops in their CD4 count. So the infections are really related to the decline of CD4. Next slide. And so if you look at, after the antiretroviral therapy was introduced, you can see that pneumocystis was almost wiped out. And also that was combined with prophylaxis with Bactrim. But there was much improvement, much lower rates of pneumonia and bacteremia and disseminated Mycobacteria avium. And so the antiretroviral therapy really made a big difference. Next slide. What happens sometimes after you give the antiretroviral therapy is you get immune reconstitution, inflammatory syndrome. So as the cells come back, you get a florid immune response, and it's mostly commonly directed against a mycobacterial antigen. And you get paradoxical increase in some of the signs. You get increasing lymphadenopathy, you can get fever, you can get new respiratory infiltrates. And this reconstitution inflammatory syndrome is not unique to HIV, but it can happen with other immune deficiencies as well. Next slide. And this is what it looks like. You get some, again, you get some more infiltrates and lymphadenopathy. Next slide. This is an X-ray of pneumocystis. It's this diffuse interstitial infiltrate, although you can have focal infiltrates, but this is the usual typical picture. Next slide. And this is the pathology where you see the intranuclear inclusions with silver stain. Next slide. You can get TB, as I mentioned, with any immunodeficiency and with the hilar lymphadenopathy, and it's still a major problem in areas that are economically deprived and where TB rates are very high. Next slide, please. You can also get chronic lung disease from HIV, bronchiectasis, constrictive obliterative bronchiolitis, which causes a fixed airway obstruction. You can get lymphoid interstitial pneumonia, and there are reports of asthma as well, increased asthma. Next slide. So in our prospective study of the HIV infected and HIV uninfected children that I mentioned earlier, we followed X-rays, and we had the radiologists read the X-rays without knowing the cases in which group they belonged, and they were three studies changes that they were looking at: parenchymal consolidation for greater than 3 months. So these were, and they had to be. This is the definition of chronic radiographic changes. Nodular densities for greater than 3 months, or increased bronchovascular markings or reticular densities for greater than 6 months. So these were our definitions of chronic radiographic changes. And next slide. And these changes correlated with clubbing, with crackles, low oxygen saturation. And actually there were cases of pneumocystis that were chronic, that weren't acute, and tuberculosis. Next slide. And as the children got older, the HIV infected children had more and more chronic changes. And you can see the ones that weren't infected, the orange line, they did not have these changes. Next slide. And these chronic changes, again, just like the acute changes, were related to decreases in CD4 cell counts. So if you look at the top line, that's children who were HIV negative and had no chronic radiographic changes. And you can see the CD4 counts just go down slowly, which is what usually, which is the normal rate of development of CD4 counts in children. But the ones that, the bottom line, the HIV positives and with chronic lung changes, you can see that their CD4 counts are low. So just to reiterate then, CD4 counts are associated with acute respiratory changes and also with chronic respiratory changes. Next slide. And here you can see just some chronic infiltrates. Next slide. LIP, I think it may be a little hard to see, but there you can see the nodular changes diffusely. Next slide. And what LIP is pathologically is you have this infiltrate of lymphocytes in the interstitium. Next slide. And you also get this bronchial-associated lymphoid tissue. Sometimes the lymphocytes, the infiltration is around the bronchioles and the bronchi, and that's what gives you the nodules. And this is also seen in other immunodeficiencies. This is not unique to HIV. It's where you have these nodular changes that are really associated with the chronic immune deficiency. Next slide. And this is this bronchial-associated lymphoid tissue. Sometimes they're just nodules that can constrict the lumen and cause some airway obstruction as well, and may lead to bronchiectasis. Next slide. In transplants, similar to HIV, you get post-transplant lymphoproliferative disorder, the PTLD. So that's really what I just showed you. The slides is similar to PTLD. It's seen following solid organ transplants and hematopoietic cell transplants. And it's thought to be related to the presence of EB virus. And one should suspect that this is what's going on if there's elevated EBV viral load. And the transplant colleagues, they always are monitoring EBV titers. And if you end up seeing these nodular changes, you should suspect this PTLD. Next slide. And sometimes it can actually progress to lymphoma. So you can get some malignancies, both with HIV and with children who are on immunosuppressive therapy. In HIV, and we don't see this in other immunodeficiency diseases, but Kaposi's sarcoma, we don't see that much in children, although it's reported in adults. Next slide. And so, as I mentioned earlier, if you get some obstruction or recurrent pulmonary infections, you can get bronchiectasis, and 12% of children with HIV ended up with, in some series, end up with bronchiectasis. Children with LIP develop bronchiectasis, and sometimes after tuberculosis as well. Next slide. And looking at long-term lung function, there have been more and more reports recently of chronic lung disease in children, or chronic pulmonary changes, pulmonary function changes in children who are perinatally infected with HIV. And this is looking at children, adolescents who are on antiretroviral therapy, and they still have changes. This is from South Africa. But antiretroviral therapy in this series wasn't necessarily started at birth. And they saw evidence of airway obstruction. The FEV1 was down, FEV1 FEC was lower, and they had some diffusion abnormalities. Next slide. And this is another series. This is from the US. This is looking at adolescents who comparing children who were infected and children who were exposed but uninfected. And you can see that there was no difference in FEV1 or an obstructive pattern, but a significant number had an obstructive pattern in the two groups, nearly a quarter. But what was interesting, if you look at bronchodilator reversibility, the ones who were HIV exposed were more likely to have reversible airway obstruction than the children who were infected. So what this tells you is, I think that the HIV unexposed is a population, when you see a 24% pattern of obstruction, that probably reflects asthma in those children. And in inner city areas, that's not too unusual to have 20%, 30% of prevalence of asthma. But the bronchodilator reversibility is less in the HIV infected, implying that they have more fixed airway obstruction. Next slide. So that fixed airway obstruction in HIV could be from prior infections. It might be that there's some immune dysregulation and it's associated with the virus causes some inflammation. There could be non-infectious pulmonary complications and some bronchiolitis obliterans. So those are the chronic changes that may cause abnormal pulmonary function in HIV. Next slide. So the research questions that we still don't know, and really, is airway obstruction in HIV infected adolescents a precursor to COPD? Does HIV exposure in utero, which is a large population, affect lung growth and development in uninfected infants? What's the long-term clinical outcome of HIV-exposed uninfected children? And what models are best to improve early access to heart in resource-poor countries? And I think that's a major public health problem for those of you that are interested in global health. Next slide. Now, just to go on, this applies to HIV and all other immunodeficiency diseases. What roles do CMV and non-tuberculous mycobacteria and fungi play in HIV and other immunodeficiency diseases? Next slide. So this is CMV, and you see these inclusions in the lung, and that's really CMV pneumonia there. But we don't often see that. What we do is we usually find CMV on lavage, and the question is, what does that mean? Next slide. We know that, at least this is in HIV, if you're immunodeficient, that you do acquire this is looking at the cumulative percentage of CMV, children with positive CMV, and over time, this is in the blood, and that HIV-infected children acquire CMV or exposed to CMV earlier than the uninfected. Next slide. Now, isolated pulmonary disease with non-tuberculous mycobacteria or CMV is uncommon in HIV infection. We don't really see just pulmonary CMV or non-tuberculous mycobacterial infections. I think they're a marker of more severe immunosuppression, and that might be that if you do see it in the lavage, it may be that you're getting the CMV from blood contamination rather than infection in the lung itself, and you're more likely to get CMV find CMV in the liver or rather than in the lung if you want to make the diagnosis. Next slide. So this is a study that was done. They had 34 BAL specimens, bronchoalveolar lavage specimens in children that were positive for CMV. These children were less than 19 years of age. 12 of them had associated transbronchial biopsy, none of which confirmed the CMV infection. 79% weren't treated, and 47% had a second pathogen detected in BAL, and 9% had rejection. And so there was probable CMV in only one patient. Again, making the point that finding CMV in bronchoalveolar lavage fluid in immunosuppressed children does not necessarily make the diagnosis of CMV. Next slide. So here's a 15-year-old male, a case report with a history of allogeneic bone marrow transplant, a 3-week history of cough, and a CT scan shows bilateral nodular lesions. Next slide. Serum galactomannan was negative. The BAL galactomannan was positive, and fungal cultures from the BAL grew Aspergillus fumigatus. Can I have the question, please, Liz? Liz? Oh, yeah, okay. Oh, sorry, I have to give you, yeah, okay. So how would you interpret the results? Proven invasive pulmonary aspergillosis, probable invasive pulmonary aspergillosis, or does not meet criteria for invasive pulmonary aspergillosis, or it reflects colonization. Okay, so so B is the correct answer. Oops, sorry, we finished? Oh, stop, yeah. And we had answers all over the place, but you know, the answer is probable invasive aspergillosis, because in order to be proven, you do have to have a tissue proven, some tissue proof of aspergillus, and that's the general consensus. And if you don't have a BAL specimen or some tissue specimen, at least growing not tissue, but if you don't have some fluid with aspergillus, a secretion or something, or a BAL, it's probable as opposed to, well, it's not. It doesn't meet the criteria if you don't have those. Next slide. Can we remove the sharing the poll? I can't see. Or
Each person has to X out.
Oh, okay. Yeah. Okay.
Monitor.
Yeah. Okay. Next slide. The risk factors for invasive pulmonary aspergillosis are hematopoietic or solid organ transplant, high-dose corticosteroids. That's really one of the very important things. If you're on high-dose steroids, the chances of getting aspergillus are much higher, and neutropenia. CT scan shows well-circumscribed nodular lesions. And so those are the things that you should suspect for aspergillosis. Next slide. Now, in lung transplants, there was the centers that are doing lung transplants in pediatrics a while back were following these children prospectively and reported 59 pediatric lung transplant patients. 17% had pulmonary fungal infections. Only 3 were proven. So again, hard to prove. They thought the other 10 cases were probable. And it was Aspergillus, Candida, and Penicillium. Next slide. Now this is a 10-year-old girl with lingering cough with colds and autourea since 2 years of age. She was diagnosed with asthma at 6 and treated with inhaled corticosteroids and improved. She remained off medications despite recurrence of a chronic cough. She developed thrombocytopenia and splenomegaly at 7 years and treated with corticosteroids for ITP, idiopathic thrombocytopenic purpura. At 10 years, she had chronic cough and crackles, and a chest x-ray showed bilateral patchy infiltrates, atelectasis, and probable bronchiectasis. Her IgA was down, her IgG was down, her IgM was normal, and the response to the tetanus, measles, mumps, and varicella, she didn't have antibodies. Next slide. And this is a picture of common variable immunodeficiency. It's the most common severe form of antibody deficiency syndrome. The age usually peaks in the 20s and 30s, but can present in early childhood, as this girl did. It has 3 characteristics: infections, autoimmune disease, inflammatory lung and GI disease, and a possibility of malignancy. So this girl had ITP, which was autoimmune manifestation, and had had recurrent pulmonary infections, which were first diagnosed as asthma, but eventually she ended up with bronchiectasis because these were really infections and not asthma. And the diagnostic labs are that she has low immunoglobulins and an impaired antibody response to specific antigens. Next slide. This is a 7-year-old boy with no history of recurrent infections. He was treated for pneumonia with infusions with intravenous antibiotics for 2 weeks and a chest tube for 5 days. He was readmitted 1 week later due to persistent fever and cough after 2 weeks IV treatment for necrotizing right lower lobe pneumonia. And you can see the x-ray, he has the effusion and he has this right lower lobe pneumonia. Next slide. His CBC was normal. His immunoglobulins were normal. The lymphocyte subsets were normal. Sweat chloride was normal. He had a bronchoalveolar lavage, which showed Burkholderia cepacia. Next slide. Oh, actually, before you go to the next slide, can you give us the questions? So what's the most likely diagnosis? Primary ciliary dyskinesia, chronic granulomatous disease, ataxia telangiectasia, Wiskott-Aldrich syndrome, or combined variole immunodeficiency? Do I end the polling or they do? Liz, do you?
You can go ahead and end it, Meyer.
Okay, stop. Okay. Yeah, so, oops. Yeah, so that's, next slide, please. Next slide. By the way, yeah.
My computer froze. Give me 1 second.
Okay. So anyway, that was the right answer. It is chronic granulomatous disease. That was the most popular answer, and that was the correct answer. Yeah. Okay, next slide. So the way you diagnose it is the dihydrorodamine assay, DHR, and basically it stimulates the phagocyte, the cells, and at the control, there's no fluorescence, and once the NADPH, which is what's gone, what's not being produced, and you don't get this respiratory burst in chronic granulomatous disease, you get a fluorescent green reading, and that's the way you make the diagnosis. So on the control, you can see you get a burst, but on the right-hand panel with the X-linked, you don't get any burst and no fluorescence. Next slide. It can also diagnose the autosomal recessive, where you get a little bit of change, and the carriers, which have a normal a burst and an abnormal and no burst. So you can actually diagnose carriers that way as well. Next slide. And so there's defective phagocytosis and the NADPH oxidase enzyme, resulting in failure in intracellular killing. And there's increased susceptibility to bacterial and fungal infections. Most of them are X-linked, and autosomal recessive is about 30%. Next slide. Now, there are also genetic diseases that are associated with immune deficiencies, which you should think about when you're looking at, being asked to consult on children with pulmonary infiltrates, infections, or abnormal X-rays. One of them is Down syndrome, which is they have more frequent and prolonged respiratory infections, and DeGeorge syndrome, ataxia telangiectasia, which has both cellular and humoral immune defects. They get recurrent sinopulmonary infections, bronchiectasis, and interstitial fibrosis. And some centers, there are some programs that have ataxia telangiectasia centers to follow these children. Wiskott-Aldrich syndrome is a B cell, T cell, and natural killer cell abnormalities. They get recurrent otitis, sinusitis, or pneumonia. So next slide. So what's the approach when you suspect a child with an immune deficiency? I mean, first you have to suspect it. Obviously, you do a CBC, you can do immunoglobulins, certainly to find if there's a common variable immune deficiency or some other immune subclass deficiency. And you do the antibody response to polysaccharide vaccines and like pneumococcal vaccine, tetanus, and diphtheria. So this is when you're doing a consult and getting these children with sort of recurrent pulmonary infections, those are the three things that you probably would pretty basic to do. Of course, besides a sweat test and possibly PCD, look for PCD. And you might then, once it gets more sophisticated, you can consider immunophenotyping for B cells by flow cytometry. And what that would tell you would be the number of B cells. And if obviously they're deficient, it would be help you with the diagnosis. And genetic testing, there's so many diseases now that are can be diagnosed through genetic testing through these microarrays and whole exome sequencing. And again, look for HIV if you suspect that that's a possibility. Next slide. And you would do a chest X-ray, a chest CT scan, look for bronchiectasis on the CT scan. One can do induced sputum to look at the organisms, or one can do bronchoscopy with bronchoalveolar lavage. And the case I presented with CGD, when we did that case, the reason we thought of CGD was because of the lavage. Burkholderia is, if you find that in a non-CF patient, that's really a very high on the list, the diagnosis of CGD. So that's how we got there, not because we were so smart, but that's what you should think of if you get that organism. You could do a needle biopsy or a transbronchial biopsy. You could do VATS or an open lung biopsy. I think for interstitial diseases, getting some tissue, especially through VATS, may give you a higher yield. You could do a nasal swab to see if there's a viral infection. You could do blood culture to see if there's a bacterial infection. You can do a urinary antigen test, for example, for, slipped my mind, but actually you could do it for CMV, but Legionella, sorry. That's what it was. So those are the different things that you can do. So in summary, we learned a lot from the HIV infection. We know that CD4 cells are important, T cells are important. We know what infections are associated with those. We, again, as we do more immunosuppressive therapy, we do more transplants, we're learning more. However, making the diagnosis can be difficult of exactly what's going on. But what you really prefer to do is not to sort of give everybody the kitchen sink when you're treating them, because there'll be more complications from the treatment than they are from the disease. And so if we can get as specific as you want. So if you're looking, for example, for pneumocystis and it's negative in the lavage, it's less likely, you may want to withdraw therapy as opposed to continue therapy. You should, make sure that when you do the lavage, you do something with the result. And it could be just withdrawing therapy, which could be helpful. And let me just mention also about PCP. With HIV, the PCP load was so high that if you didn't have it, you didn't have PCP. The problem is with some of the immunosuppressive diseases or with chemotherapy, the load may be a little lower, so you're a little less sure, but that it's not a negative result is not PCP. But it's pretty specific. So I think that, again, use the lavage and make sure that you do something with the results. And I think that's the end of the talk. And I'll be happy. Are there any questions, or can we take questions?
Yeah, we sure can, Meyer. People can put it in the chat box and we can read them. And I'd like to start with one. So as you started your talk, I went to medical school. I started in 1986. So I started to write down just some epidemics off the top of my head in my career, which has actually gone by remarkably fast. As a medical student and resident, we were dealing with HIV. And then during fellowship and early faculty, we saw, not so much in pediatrics, but, MERS and SARS. In residency, I saw measles. We had measles outbreak in the early 1990s. We've had a second measles outbreak in the last few years. We've seen H1N1, enterovirus D68, now COVID. And so as you look back, and you were on the front lines during the HIV and also experienced all of these things, is there a common thread amongst these? And what can we do besides, adhering to public health and policies and recommending behavioral changes? How can the pulmonologists, especially those of us who are starting out, what should we be vigilant for based upon your experience, and what have you learned?
Yeah. So the point is that, to be alert that when you start seeing a few kids with sort of unusual diseases, that you start, worrying about something new occurring. Now, with the HIV, this was straight out of fellowship, and then all of a sudden we're seeing all these kids, and if you don't have a high index of suspicion of something going on, then we don't know how to treat them properly. And in New York, when we had so many cases at the time, but in other places, people weren't suspicious. We knew, for example, that if a kid came in with hypoxemia, this was HIV until proven otherwise. And it took, actually, I had a resident who went to another state in the South and for a fellowship in a pretty prominent place. And she was shocked that they weren't diagnosing, they weren't suspecting it early on. And I think that and this was a couple of years after the epidemic started. It was so obvious to us, but it wasn't obvious to people who weren't accustomed to seeing this. The other thing is that politics does get involved, as you can see with COVID. And we have to be spokesmen and represent our kids. With HIV, as I mentioned, this ACT UP, it took years to get the politicians to put money, and people thought, well, it was a homosexual disease, nobody was interested. And then when it started to affect heterosexuals, then people got interested. And actually, it was Ronald Reagan, as a result of all this ACT UP, that actually decided to support it. And I think that with Ebola, when that came around, all sorts of stigmas that were associated with it. People were isolated. People were prevented from doing certain things. And, this keeps going on. We keep repeating ourselves. And with COVID, I think the same thing is happening. People want to believe what they want to believe, and we have to believe science.
I think that's a great point, being vigilant. I had a similar situation. You know, I did my residency in Chicago, and we saw a ton of HIV. And then when I did my fellowship, there wasn't as much there. And I went in to do a consult as a first-year fellow of a patient with chronic diarrhea on the GI service and failure to thrive and hypoxemia and candidal thrush and perianal candidal rash. And I walked in the room, I'm like, well, what's the HIV test? And no one had even thought about it because they just didn't see it. Of course, he had HIV and also, you know, tuberculosis. So I think being vigilant is very important. And a lot of those theories about HIV are still out there. I recently talked to a college student who is you know, 4.0 student who said he wasn't worried about HIV because he's not an IV drug user or a homosexual. And I'm like, did you have sex ed in high school? You know, so some of that is still out there, and we have to be always aware and keep our suspicion.
Yeah, I think we don't see the vertically transmitted, the infants that we saw earlier, but adolescents, you should, you know, always think about HIV as a possibility.
Yeah. Any questions in the chat box, or, you know, we can unmute you as well. It is 5 o'clock, but any other questions? Meyer, by the way, thank you. I always enjoy this talk every year. And, you know, and I know it's hard for people who haven't lived through it to, I just remember the night Magic Johnson announced on national television that he had HIV, and that was like it was like the first time that it really hit home for a lot of people that a star athlete in the prime of his career could get HIV, and you know, it was a very poignant moment. I was actually on call that night. So, all right. Well, please fill out the survey. We really appreciate it. And Meyer, thank you again for doing this and adapting to the virtual talk. And we have 2 talks next week. And take care, everybody.
Okay, thank you. Bye-bye.
Bye-bye.
Stay safe. Okay.